Good afternoon, Madam Chair and members. Again, John Hawkins, Texas Hospital Association, testifying for House Bill 3197. Again, not to belabor any of the points, but I think it is important to note that from the hospital perspective, it really is all about expanding coverage. Basically, we can't sustain a business model that includes the federal cuts that have already been implemented, as Representative Howard indicated, both to fund ACA, now sequestration, which is another 2%. Those cuts were made with the trade-off of coverage expansion, recognizing that that actually allows us to re-engineer our business model, focus more on primary care wellness as opposed to a sick care system. And so at the end of the day, we support any innovative effort to create expanded coverage. And personal responsibility is an important piece of that. And I certainly recognize the attempts to do this. In fact, we argued during the ACA for more private market coverage as opposed to reliance on Medicaid. Unfortunately, since the bill didn't get sent to conference, they cheaped out and did about half expansion, half Medicaid. So we certainly support a private market solution. That works better for all providers. It works better for clients as well. So we believe this it goes a large way toward that. Remember, at the end of the day, this will help reduce coverage, does help reduce reliance on hospital ERs. It helps reduce uncompensated care, which benefits the private market and local taxpayers. It also has a clinical improvement. Coverage works better than care in an ER after the fact. And so we support this effort, certainly stand ready to continue the discussion, and appreciate your work on this issue.
Great, thank you. Chairman Copeland. Quick question. John, did the Affordable Care Act or did Medicare get cut through the Affordable Care Act? Everybody talks about we got cut through the Affordable Care Act.
Yeah, so what they did, they didn't cut the benefit per se, but they cut providers by about $500 million. So they cut provider payments, pretty much everybody except the physicians, because they didn't touch the physicians because the SGR problem is a separate issue. So I think where the disconnect is, people will say Medicare was cut. Well, the beneficiary wasn't cut directly, but they're taking over 10 years $500 billion out of provider payments, and we're actually taking those payment reductions beginning in 2011, even before the coverage comes into play. So that's the way it works.
Good afternoon, Chairwoman Crownover and members of the committee. I'm with the Teaching Hospitals of Texas, so it's an association that includes some groups that are the large public transferring hospitals in Texas, as well as some University of Texas healthcare systems and some other nonprofits. I'm the president and CEO of THOT, and I'm here today to testify for 3791. We think that this bill, first of all, we'd like to thank Chairman Zerwas for his leadership on ensuring an opportunity to cover individuals who are uninsured today and doing so in a way that works for Texas. So we appreciate his leadership and vision on that. Second, we support the efforts to negotiate a program that gives Texas options. You've heard the discussion about options and opportunities, and so we look forward to this opportunity. We think that this provides Texas with an approach really that's going to make for a more efficient healthcare system and use funds wisely. John also mentioned with TACHC the use of federal funds, and so you see from my testimony, I think I tried to cite the Medicare reductions. Chair Colcourse, you could see some of the reference to where those are coming from, but those are reductions that have already taken place at the federal level, so we see the advantage of securing those federal funds that are available and to be used in Texas, since they've already been taken away from the hospitals in Texas. In particular on the Medicare side. Of course, in 2014, the Medicare DSH hits, the cuts hit there, and also Medicaid DSH start to reduce a little bit. So those are additional hits or cuts to hospitals in the future. And so we see the federal funds as being a great opportunity for Texas to take advantage of, again, in a way that supports coverage for the uninsured. I guess the last thing that we would mention is that the way that Chair Zerwas has envisioned this approach, it provides health care in a way that provides consistent coverage. So you've heard testimony earlier about the woman's son who has ad hoc care. And so while there is maybe in a sense worst case coverage in some communities are a little bit better. They cover up to say 300% in indigent care programs. But often they're ad hoc. And so we see coverage initiatives such as those articulated in this bill as an opportunity to provide care in a system that provides coordination and that's consistent and provides access to a usual source of care. Finally, we also know from the literature that people who do have insurance, Medicaid or other forms of insurance who have coverage, such as that envisioned by the bill, are actually better off than people who are uninsured. So we know that from the literature. I know there's some debate on that, but that's what the literature suggests. If you believe in political check fact, I think they conclude as much. So just to kind of bring that into the discussion. So that's all we wanted to share, and be happy to answer any questions. But again, we appreciate your leadership and consideration. We know this is a difficult issue, but a great opportunity for Texas. So thank you.
Great. Thank you for
Madam
taking
Chair,
the time.
my name is Jose Camacho. I'm the Executive Director and General Counsel for the Texas Association of Community Health Centers, and I'm testifying on the bill. Let me first thank Dr. Zerwas and Mr. Turner for bringing this issue forward, and thank the committee for the spirited discussion. I'm handing out two items to you. One is our fact sheet, and the other is a frequently asked questions on the Medicaid and Affordable Care Act premium assistance, the program that you are considering today in the bill. And before you read, flip over to the second page to the highlighted area. I want to make one point. Yes. This guidance is in effect until the end of December 2016. The reason for that is that at that point, a very broad waiver authority that was included in the ACA kicks in. That waiver authority allows for a much broader consideration of the issues and would no doubt encompass the 1115 that's been discussed today. Until that time, this is the guidance for premium assistance programs, and is fairly straightforward in terms of what can and can't be done. The idea being that if we can get to the position of drawing down the federal money, of accomplishing the match, then the ideas that have been put forward on a Texas-specific solution become much more doable after this waiver authority kicks in. The second point I'd like to make is on the fact sheet. There's been a lot of concern about copays. Health centers are public and not-for-profit entities that provide coverage, primary care coverage to the uninsured and underserved. Last year, we served just over 1 million people, 51% of them uninsured, 72% of them under 100% of poverty. If you look at the back page, the patient self-pay indicates that we received $68 million from the self-insured patients. Patients who are uninsured are willing to pay for quality health care, but they understand a good deal. And so if you fashion something that is a good deal, people will respond. By mission and mandate, we can't turn away anybody for inability to pay, but I think we're living testament to the fact that patients are willing to contribute. Thank you, Dr. Zerwas, for bringing this forward. The only reason we're testifying on and not in favor is that we'd like to work with you to fashion something that meets the premium assistance, that is a new approach, and that can evolve into the solutions that Texas is looking for. Thank you all very much.